Good afternoon, everyone, and welcome to Public Health Ontario's Rounds presentation titled, Let's Talk About Syphilis, a Case-Based Clinical Overview. My name is Austin Zygmunt. I'm a public health physician at PHO and work on sexually transmitted and blood-borne infections. I have the pleasure of moderating today's session, and I have no conflicts of interest to declare. Before we begin today, many of you are probably living and working in an area with an extreme heat warning this week. So I wanted to take an opportunity to highlight that many local public health unit websites have resources on extreme heat, and Environment Canada's WeatherCan app is a useful resource for weather updates and messages. This is also a good time to check in on friends and neighbors, particularly those that are isolated or live alone, have limited mobility, or don't have air conditioning. So now a few housekeeping items. The chat pod has been disabled to limit any distractions during the presentation. Please use the Q&A pod if you have questions during the session, and we will have a discussion following the presentation. If at any point during the session you experience any technical issues, please email capacitybuilding@ohpp.ca. It is now my pleasure to introduce the speaker for today's presentation, Dr. Andrea Chittle. Dr. Chittle is a medical advisor in the Sexually Transmitted and Blood-Borne Infections Surveillance Division at the Public Health Agency of Canada. She completed her family medicine residency at McMaster University and a Master of Public Health at the University of Waterloo. She has worked as a consultant physician in the sexual health programs of 3 Ontario public health units and operated an HIV pre-exposure prophylaxis or PrEP clinic. In her role at PHAC, she has been involved in the development of healthcare provider resources, including a syphilis toolkit. So I'll hand it over to Dr. Chittle to get us started today.
Thanks so much, Austin, for the introduction, and thanks to everyone who is joining the webinar today. Over the next 40 minutes, I will provide a clinical overview of syphilis. I will use 2 case examples to review the national recommendations for syphilis screening and management, and will showcase some Public Health Agency of Canada resources for clinicians. Some colleagues from PHAC are also online, and you may see them responding to questions in the Q&A area. I created this presentation with support from my colleagues at PHAC. It will be published on the Public Health Ontario website for public use, but Public Health Ontario does not own this content, and application or use of the information is the responsibility of the user. I want to note, especially because it's lunchtime, that the presentation includes clinical images of a graphic nature. As Austin mentioned, my training is in family medicine and public health, and I am a medical advisor at the Public Health Agency of Canada. Much of my clinical work and my work at PHAC has focused on syphilis. I worked on this presentation as part of my paid role at PHAC. I don't have any other financial relationships to disclose. I will share some PHAC materials throughout with permission and attributions, and I'm really grateful to have had the opportunity to collaborate with brilliant coworkers to develop some of the materials that I will share today. After attending the presentation, I hope that you will be able to refer to, recall, and implement national screening and management recommendations for syphilis, explain the role of epidemiologic information, clinical exam findings, and test results in the diagnosis of syphilis, and depending on your role and context, support or directly provide treatment and follow-up to individuals diagnosed with syphilis infections following national clinical recommendations. For context, I will start with a high-level summary of recent epidemiologic trends in infectious and congenital syphilis in Canada. I will then use 2 cases to review recommendations for syphilis screening, testing, treatment, and follow-up. I'll begin by reviewing some epidemiologic trends. So after decades of decline, infectious syphilis rates began to rise steadily in Canada in the early 2000s, and we have seen substantial increases since 2017. The rate among males continues to be higher than among females and is partly related to the disproportionate burden experienced by gay, bisexual, and other men who have sex with men. However, in recent years, the rate of infectious syphilis has been increasing more rapidly among females. Between 2013 and 2022, the rate of infectious syphilis among males nearly quadrupled, while the rate among females increased more than 31-fold. Increases among females have been particularly pronounced among those in their reproductive years, and as a result, there has been a sharp rise in cases of congenital syphilis. Between 2013 and 2017, there were an average of 4 cases of confirmed early congenital syphilis reported per year in Canada. In 2022, there were 117 cases of confirmed early congenital syphilis reported nationally. Rates of infectious syphilis and congenital syphilis vary widely between Canadian jurisdictions. And in 2022, Alberta, Saskatchewan, Yukon, Northwest Territories, and Nunavut had rates of infectious syphilis that were higher than the national average. A study conducted in Manitoba found that infectious syphilis detected with direct syphilis tests rose much more rapidly in rural settings compared with urban settings between 2017 and 2020. And this points to some of the social and structural determinants of health that are contributing to the inequitable distribution of syphilis, which include housing instability, experiences of violence, stigmatization, discrimination, and racism, and lack of access to culturally safe care. Now I'll move on to reviewing some clinical cases and their assessment and management. You can access FACT's evidence-based recommendations on syphilis screening, diagnosis, and management online in the STBBI guides for health professionals. And this information is also available in a mobile app. The first case that I'll discuss this afternoon is Anna, and she is adapted from a published case. The name is one that I selected. So our first case, Anna, the first time you encounter her, she's 21. She's a cisgender woman who presents for a first prenatal visit. And by her last menstrual period, the gestational age is estimated to be 7 weeks and 1 day. Anna has no significant past health history and is not taking any prescribed medications. She has no known drug allergies. So this is a screenshot of a double-sided infographic that we worked on called Let's Talk About Syphilis, and it summarizes the Public Health Agency of Canada's syphilis screening, treatment, and follow-up recommendations. And you should be able to get to the landing page where a number of our health professional resources are held using that QR code. The national recommendations for syphilis screening and pregnancy have been prioritized for review, and that work has started. The current recommendations are to screen pregnant individuals for syphilis in the first trimester or at the first prenatal visit, and in areas experiencing outbreaks and for people at ongoing risk of infection, screening should be repeated between 28 and 32 weeks gestation and again during labor. So based on local epidemiology, some Ontario health units currently recommend routine screening of all pregnant individuals at these 3 time points: first prenatal visit, 3rd trimester, and again during labor. So here are the syphilis screening results for Anna, and I'll review the serologic tests for syphilis and the algorithm in the next part of the presentation, but during this pregnancy, Anna's screening syphilis test is non-reactive. So 8 years later, Anna presents to care as a syphilis contact. At this time, she is 29 years old, and she discloses that she is pregnant, but with an uncertain last menstrual period, and she has not received any antenatal care so far in this pregnancy. This is her 4th pregnancy, and her 3 children were born at term by vaginal delivery. She has no other past health history, isn't taking any medications, and doesn't have any drug allergies. So Anna hasn't noticed any signs or symptoms of syphilis, but her physical exam is remarkable for a non-tender, shallow vulvar lesion at the posterior fourchette, and her uterine fundus is palpable 2 centimeters below the umbilicus. This one is a screenshot of a resource that is included in a new visual staging guide for syphilis that we developed. And the visual staging guide is accessible at the same QR code that I previously showed, and which I'll show again on the next slide. This infographic shows clinical exam findings that can support the staging of a syphilis infection. In general, diagnosing syphilis involves combining test results with a clinical staging assessment. And as many may know, syphilis has been referred to as the great impersonator because it has so many clinical manifestations. Generally, syphilis infections progress through different stages. The primary, secondary, and early latent stages are referred to as infectious syphilis because of the higher risk of syphilis transmission during these stages. Individuals may develop characteristic symptoms or non-specific symptoms, or they may not notice any symptoms at all. In some cases, characteristic features of a syphilis infection are only discovered during a comprehensive clinical exam that is performed to assess someone who has had a reactive serological test. Importantly, the stage of infection informs decisions about treatment, follow-up, and contact tracing. The hallmark of primary syphilis is the chancre, which often goes unnoticed by patients. Signs and symptoms of secondary syphilis can develop as the chancre is resolving and can include constitutional symptoms and a body rash. Latent syphilis is not associated with any signs or symptoms. By definition, early latent syphilis spans the first year after infection, and late latent syphilis is an infection lasting longer than 1 year. Early and late neurosyphilis can occur. Early neurosyphilis occurs in the first year after infection, and it can be asymptomatic or present as meningitis, cranial neuritis, or uveitis, among other findings. Late neurosyphilis occurs more than 1 year after infection, and it can present with personality and cognitive changes, weakness, coordination, and balance impairment. The visual staging guide contains images of characteristic features of syphilis infections, and as I mentioned, the chancre is the hallmark feature of primary syphilis. It typically begins as a painless papule at the site of inoculation, which could be genital, perianal, or oral. The papule then ulcerates and appears as a 1 to 2 centimeter round lesion with a raised, indurated margin and non-exudative base. Multiple chancres can occur, particularly in the context of HIV, and there can be associated regional lymphadenopathy. These lesions generally heal spontaneously within 3 to 6 weeks. There are a number of screening and diagnostic tests for Treponema pallidum, the bacteria that causes syphilis. These tests include conventional serologic tests, direct tests of ulcers or rashes, and tests of cerebrospinal fluid. Conventional serologic tests are used for syphilis screening, and testing follows an algorithm that includes treponemal tests and non-treponemal tests. I'll share a schematic of different algorithms on the next slide. Treponemal tests are for antibodies against Treponema pallidum. Test results are usually reported as non-reactive or reactive, and once someone has had a syphilis infection, these tests usually remain reactive for life. Non-treponema serological tests are quantitative tests for other antibodies, and these test results are reported as titers. Titers at or above 1 to 8 are often used as a surrogate for infectious syphilis, although non-treponemal tests may become negative after early infections. Titers generally decline over time and after treatment. Non-treponemal tests, as I said, can become negative after treatment and in some untreated late syphilis infections. In some instances, they remain at a stable, usually low level following treatment. They are less likely to become negative after reinfections. And I want to briefly mention syphilis point-of-care tests because these are pretty topical. Point-of-care tests for syphilis may detect treponemal and or non-treponemal antibodies. There are 3 broad categories of syphilis point-of-care tests: treponemal-only point-of-care tests, combined treponemal and non-treponemal point-of-care tests, and point-of-care tests that detect treponemal antibodies in addition to other viruses or bacteria like HIV. Currently, there is only one syphilis point-of-care test that's approved for use in Canada. It's the biolytical Insti multiplex HIV syphilis antibody test. Health Canada has licensed this test for use in medical facilities, clinical labs, emergency care situations, and physicians' offices. and for people with signs and symptoms of HIV and syphilis. So this means that the use of this point of care test for syphilis screening and outside of clinical and lab settings are off-label uses. There's a MedMira dual HIV and syphilis test, and it has been submitted to Health Canada and is under review. Most labs in Canada use the so-called reverse algorithm to process serologic samples submitted for syphilis testing, and it's called the reverse algorithm because it flips historical algorithms that started with a non-treponemal test. So this slide depicts the algorithm used in provinces and territories in 2009. In the reverse algorithm, the first test is a treponemal test. In Ontario, this is the CMIA test. If that test result is reactive, confirmatory testing is done, usually with a non-treponemal test, and in Ontario, this is the RPR. Depending on historical results, the non-treponemal test may be followed by a second treponemal test, which in Ontario is the TPPA. This table shows the most common combinations of syphilis serologic results. As I mentioned, treponemal test results are reported as reactive or non-reactive, and reactive treponemal tests are followed with a non-treponemal test, which is reported as a titer. The titer values for non-treponemal tests and the trends in those test results are really practically valuable. Serial titers confirm treatment effectiveness, and titers support clinicians in detecting reinfections and diagnosing congenital syphilis. In infectious syphilis, which again includes primary, secondary, and early latent syphilis, you will generally receive a positive screening treponemal test result and a positive non-treponemal titer. So returning to the case, here are Anna's preliminary investigations. In your setting, we're going to imagine that you have the biolytical dual HIV and syphilis point of care test. And when you perform that test using a finger stick specimen, the syphilis component is reactive and the HIV component is non-reactive. And an ultrasound confirms a singleton pregnancy at 18 weeks and 2 days with no abnormalities. So this slide shows another section of the Let's Talk About Syphilis infographic. The FAC guides recommend managing syphilis in pregnancy in consultation with an obstetric or maternal fetal specialist, and there is no satisfactory alternative to injectable, long-acting penicillin in pregnancy. Infectious syphilis is generally treated with a single 2.4 million unit dose of long-acting penicillin G. However, some experts suggest a second dose administered 1 week after the initial dose in pregnancy. And Ontario resources generally refer to the FAC guides for syphilis treatment recommendations, so this would be applicable in Ontario. The Jarisch-Herxheimer reaction is an acute febrile reaction that can occur after the administration of penicillin for the treatment of early syphilis, most often secondary syphilis. The reaction is generally self-limited and can be managed with antipyretics. People may experience fever, chills, myalgia, arthralgia, headache, and in the context of secondary syphilis, an exacerbation of rash. In pregnancy, the reaction has been associated with fetal distress and preterm labor, with widely varying reaction rates reported in the literature. The FAC guide suggests that in the absence of abnormal findings on ultrasound, syphilis in pregnancy can be managed in outpatient settings, and pregnant persons can be advised to seek medical attention for fever, uterine contractions, or apparent decreases in fetal movement. Local practices may vary. When you receive the results of Anna's lab test, they confirm your initial diagnosis of primary syphilis. Direct fluorescence testing of the vulvar lesion detects treponema pallidum, confirming that the lesion was a chancre. Serologic test results are also consistent with an early syphilis infection with a reactive screening CMIA and reactive confirmatory RPR. Anna's titer is quite high at 1 to 64. The syphilis toolkit that we've developed contains a simplified algorithm for clinical staging. This is an updated version of an algorithm that was developed by Troy Grennan and Todd Hachette, members of the National Advisory Committee on Sexually Transmitted and Blood-Borne Infections. The algorithm aims to support the staging and treatment of primary, secondary, and latent syphilis infections. It only includes penicillin as a treatment. So the red boxes here highlight the inputs from Anna's lab and clinical assessment, the corresponding clinical stage, and treatment recommendations. In Anna's case, we have both direct syphilis results and a first instance of a positive serologic result. She also had a chancre on clinical exam, a classic feature of primary syphilis. She doesn't have any neurologic signs or symptoms, and so the recommended treatment is 1 or 2 parenteral doses of long-acting penicillin G. And as I mentioned, it's important to advise individuals treated with penicillin about the Yarish-Herxheimer reaction and to manage syphilis infections in pregnancy in consultation with a specialist. This is a screenshot of another section of the Let's Talk About Syphilis infographic. Serial non-treponemal titers are used to confirm that treatment has been effective. In a recent study, more than 25% of people whose treatment was delayed by 10 to 14 days, there was a 4-fold or greater increase in non-treponemal titers between the initial testing and testing at the time of treatment. So the clinical implication is that if there is a delay between testing and treatment, you may want to repeat testing at the time of treatment to document the peak titer and help you to interpret follow-up results. I included the details of that study in the reference list at the end of the deck. In general, titers should be followed until they have reverted to non-reactive or a stable low titer of 1 to 4 or below has been achieved. Documenting the lowest follow-up titer can support the diagnosis of reinfections. For individuals diagnosed with infectious syphilis in pregnancy and who are at high risk of reinfection, monthly follow-up testing is recommended until delivery. Otherwise, follow-up serology is recommended at 1, 3, 6, and 12 months post-treatment. And the traceback period for sexual contacts depends on the stage of syphilis. Since Anna was treated as primary syphilis, contact tracing would extend back 3 months. In this case, as with the treatment recommendations, Ontario documents refer to the FAC recommendations, so this also is applicable in Ontario. The decline in non-treponemal titers after successful treatment will vary depending on the stage of infection at the time of treatment, the titer at the time of treatment, and whether the individual has been previously treated for syphilis. In primary syphilis, the FAC guides indicate the titer should decline at least 4-fold or become non-reactive by 6 months after treatment, and at least 8-fold or become non-reactive by 12 months after treatment. A 4-fold or greater increase in non-treponemal titer is concerning for treatment failure or reinfection. In Anna's case, an increase in titer from 1 to 64 to 1 to 256 or higher would be concerning for reinfection or treatment failure. In pregnancy, treatment before 20 weeks gestation is usually successful, and treatment failure has been associated with evidence of fetal syphilis on ultrasound, a longer interval between infection and treatment, infection in the 3rd trimester, and a higher baseline titer. So wrapping up the discussion of Anna and syphilis in pregnancy, some key messages are that the NAC-STBBI guide for health professionals recommends screening all pregnant individuals for syphilis in the 1st trimester or at the 1st prenatal visit. In areas experiencing outbreaks and for people at ongoing risk, screening should be repeated in the 3rd trimester and again at labor. History, physical exam, and current and historical lab results support syphilis staging. Syphilis in pregnancy should be managed in consultation with an obstetric or maternal fetal medicine specialist. Importantly, there is no satisfactory alternative to long-acting injectable penicillin for the treatment of syphilis in pregnancy. A decline in non-treponemal titers over time confirms that treatment has been effective. A fourfold or greater increase in titers is concerning for treatment failure or reinfection. Our second case, Chris, is a fabricated case based loosely on several different clinical encounters. Chris is a 25-year-old cisgender man presenting to an outpatient setting requesting routine STBBI screening. His last testing was 15 months ago. His partners are cisgender men, and he has receptive and insertive anal sex. He has not noticed any symptoms of sexually transmitted or blood-borne infections and has not been informed that he's an STBBI contact. He does have a past history of early latent syphilis diagnosed 3 years ago. His last RPR titer was 15 months ago, and at that time it was 1-to-1. He has had rectal chlamydia 2 years ago, and he's not taking any medications and has no drug allergies. This is a screenshot that we've already seen, but I'm highlighting a different section, the recommendations for screening non-pregnant adolescents and adults. These screening recommendations were updated last year, and generally, again, Ontario guidance documents refer to the FACT guide, so these are applicable in Ontario. The NAC-STBBI recommends screening all sexually active individuals with new or multiple sexual partners or upon request of the individual, and individuals with multiple sexual partners should be screened every 3 to 6 months. When serving population groups or communities experiencing a high prevalence of syphilis, targeted opt-out screening as frequently as every 3 months is recommended. And population groups and communities experiencing a high prevalence of syphilis include gay, bisexual, and other men who have sex with men, people living with HIV, people who are or have been incarcerated, people who use substances or addiction services, and some Indigenous communities. So here are Chris's screening results for syphilis, HIV, and urine, throat, and rectal, gonorrhea, and chlamydia. The syphilis screening test was reactive, which we expected because Chris has a known prior history of syphilis infection. And I mentioned that his prior RPR titer 15 months ago was 1-to-1. On current testing, the RPR is now 1-to-32. HIV testing and gonorrhea and chlamydia testing are also all negative. And I want to note that routine STBBI screening for Chris would include annual hepatitis C screening, and if he's not vaccinated against hepatitis B, annual hepatitis B screening. When you recall Chris for a staging assessment, he reiterates that he hasn't had any known exposures to syphilis and denies any signs or symptoms on review of systems. You conduct a head-to-toe clinical exam and do not detect any abnormalities, no rash, lesions, lymphadenopathy, no neurologic abnormalities. This is the least interesting page of the visual staging guide, but probably the most appropriate one for lunchtime. Early latent syphilis is an asymptomatic infection of less than 1 year duration. Early latent syphilis can relapse to the secondary stage, so it's considered infectious. Late latent syphilis is an asymptomatic infection of more than 1 year duration, and practically historical lab testing can confirm a diagnosis of early latent syphilis. You can confidently stage an infection as early latent syphilis if you have baseline testing within 12 months that demonstrates either seroconversion of treponemal tests from non-reactive to reactive, or in the case of a reinfection, if you see a 4-fold increase in non-treponemal titers. In Chris's case, the last documented testing was 15 months ago. So while the titer is high and suggestive of a recent infection, clinically, he would be staged as having a latent infection of unknown duration. And I just got the QR codes for our resources before the presentation, and I neglected to post that QR code on this slide, but it is the same as on the previous slides. Again, here is the simplified algorithm for clinical staging and treatment, and the red boxes outline the information that we have for Chris. Chris's RPR titer increased more than fourfold from a baseline of 1:1 to 1:32. Chris doesn't have any signs or symptoms of syphilis, and his last testing was more than a year ago. So this stage is latent syphilis of unknown duration, and the recommended treatment is 3 doses of parenteral long-acting penicillin G, accompanied by advice about the Yarish-Herxheimer reaction. There are alternatives to long-acting penicillin for the management of syphilis in non-pregnant individuals, and you can find those alternatives in the STBBI guides. The Let's Talk About Syphilis infographic summarizes the recommendations for follow-up serologic testing and partner notification. Follow-up testing and partner notification for latent syphilis of unknown duration generally follow the recommendations for early latent syphilis out of an abundance of caution. When Chris returns for his second dose of long-acting penicillin G 1 week after the first dose, he shares some information with the clinic nurse that prompt the nurse to ask you to reassess him. After the first dose of penicillin, Chris indicates that he had myalgias, sweats and chills, and that a diffuse, rough, red, non-pruritic rash appeared. On exam, you observe erythematous maculopapular lesions on Chris's trunk and extremities involving the palms of his hands and the soles of his feet. The visual staging guide contains images of clinical features of secondary syphilis. Classically, secondary syphilis presents with a skin rash, which can take any form, although vesicles are less common. It's often red or reddish-brown, maculopapular, diffuse, and asymmetric, involving the trunk and extremities, including the palms and soles. The rash can be so faint that it is not noticed. Mucosal lesions can occur in secondary syphilis. On mucous membranes, especially of the mouth, erythematous macules can develop and evolve into slightly elevated, flat-topped lesions covered by a grayish membrane. These lesions can coalesce to form what are called snail track ulcers. And condylomata lata, which are flat-top papules, can develop in anogenital mucosa and skin folds like the axilla. The lesions of secondary syphilis generally spontaneously resolve over a variable period of time. They can recur in individuals who are immunocompromised, and exacerbations of the skin rash of secondary syphilis following bicillin treatment can occur as part of the Yarish-Herxheimer reaction. I'm repeating this slide to highlight again that the decline in non-treponemal titers over time is variable. In the context of secondary syphilis, the STBBI guides indicate that an 8-fold decline in titer should occur by 6 months after treatment and a 16-fold decline by 12 months. In reflecting on Chris's case, I hope you'll take away a few key messages. The NAC-STBBI recommends screening all sexually active non-pregnant adolescents and adults with new or multiple sexual partners every 3 to 6 months. Targeted opt-out screening as frequently as every 3 months should be considered for those serving populations, groups, or communities experiencing a high prevalence of syphilis. Syphilis lab results within the prior year can be used to confirm a diagnosis of early latent syphilis. In the absence of historical lab results that can confirm a recent infection, asymptomatic individuals may be clinically staged as having a latent syphilis infection of unknown duration. Latent syphilis of unknown duration is generally treated as late latent syphilis with 3 doses of injectable penicillin G, and out of an abundance of caution, contact management is generally performed as per early latent syphilis, notifying sexual partners from the year prior to diagnosis. Our key resources that I've shared throughout the presentation can be found at the landing page that you should be able to access through that QR code, including the Let's Talk About Syphilis infographic, the visual guide for staging a syphilis infection, the algorithm for staging and treating syphilis, and an additional resource that I didn't incorporate but that people may find very helpful in their practical provision of care, and it's called Strategies for Implementing a Person-Centered Approach to Sexual Health.
Thank you, Dr. Chittle, for that great presentation. So we'll now have our question and answer period, and our Q&A pod is open. We have a few questions already. If you were focused, Dr. Chittle, on epidemiology of infectious syphilis and congenital syphilis, so wondering if you could tell us a little bit more about It's accounting for these increases in rates. I'll throw a couple questions in altogether. There's also one in the chat pod about differences between rural and urban areas, if you're able to speak to that as well.
Thank you. And I think these are complex questions, and we have some preliminary research that's giving us some insight, but overall there's a complex interplay of determinants of health and risk factors, including housing insecurity, as I mentioned, rural or remote residents, lower income, substance use, experiences of violence, lack of access to culturally appropriate care. Between 2017 and 2022, the largest increase in rates of infectious syphilis were reported in females and in individuals identifying as heterosexual. And so because of that shift in the epidemiology, we've seen that corresponding rise in rates of congenital syphilis, but impacted by these other social structural determinants of health and other syndemic conditions.
Great, thank you. There's a question around completing the third trimester testing for syphilis. So that range of completing it between 20 to 32 weeks. Is there any evidence around maybe completing it a little sooner when more general third trimester screening is done for other things at 28 weeks, or delaying it until 32 weeks? Is there any significant difference in that 4-week period?
Thanks for that question, Austin. I know that our guideline committee, as I mentioned, has prioritized reviewing the recommendations for syphilis screening in pregnancy. And so I wonder if some of that evidence will be reviewed as part of that update. I had an opportunity to attend a presentation from some colleagues who are working in Kingston, and they have implemented 3-time screening in pregnancy as a routine practice there, and are asking questions about whether they might have higher uptake of the later pregnancy screening if they did it alongside other tests like the oral glucose tolerance test in later pregnancy. Because there hasn't been as high uptake of that third trimester testing. So I think there may be some opportunities to kind of couple testing with other things that are routinely done in pregnancy to try and increase uptake, because I think they've mapped out and seen a doubling of their uptake of prenatal syphilis testing, but not a tripling as they would have expected to see if people were doing this or sending patients for testing at 3 times. And certainly there is a lot of testing that's happening in pregnancy. So yeah, it will certainly be worth looking into, and I imagine our guideline committee will look at the evidence around that too as they're reviewing the recommendations.
Had a few questions about individuals that have a penicillin allergy. Is there any recommendations for how to manage those people?
Yeah, so the STBBI guides do have alternatives to penicillin, generally for non-pregnant individuals, but I'll see if I can just pull up that slide and show it again on the screen. Generally, the oral option would be doxycycline. Obviously, I have too many slides because I can't very easily find it. It was with Chris's case and here on the screen. So you could use ceftriaxone or doxycycline for infectious syphilis in non-pregnant individuals. The doxycycline regimen is twice daily for 14 days. For latent syphilis of unknown duration, it would be for 28 days.
Yeah, we have a question around when infectivity ends after being treated appropriately for infectious syphilis. So are you able to speak to that? Does it differ by the stage as well?
That's a great question. We usually recommend abstaining from unprotected sex until individuals and their partners have completed the treatment, and at least 7 days following treatment. That was a question that came up recently, and colleagues were speaking about potentially reviewing the evidence for that. That may also come up as part of the syphilis, the review of syphilis screening recommendations in pregnancy, because I know practically it does happen that there may be a gap between doses of bicillin for individuals that are requiring multiple doses. And so there's a question about when do you need to restart a series. So something that we're also looking into, but generally the recommendation is abstain for 7 days, until 7 days after completion of treatment by the individual and their partner.
Okay, there's a question around using short-acting Pen-G and not benzathine Pen-G. If an individual is treated that way, is there a different recommendation around retreating or retesting?
My understanding is that you need to treat with the recommended regimen, which is long-acting. So if someone has inadvertently gotten the wrong regimen, then they need to be treated with the correct regimen.
Okay, I'm not sure how to interpret this question, Dr. Chittle, but it's asking if you can speak to individuals who serofast at high RPR. So is there anything specific about that group of individuals you'd like to comment on?
Yeah, so my training was that if someone is serofast at a titer of 1 to 8 or higher, we should really be ruling out neurosyphilis. So my clinical practice has been sending those individuals for a lumbar puncture. Sometimes it's difficult to determine whether someone might have had an exposure to a partner who wasn't treated or a new exposure. So there's a consideration about, well, do they have a new infection if you're not seeing the RPR decline, or have you missed a neurosyphilis infection? So in general, those individuals, in order to rule them serofast at a titer of 1 to 8 or higher, my training was you need to do a lumbar puncture and confirm that there's no neurosyphilis before you can make that diagnosis. And I have seen that, especially in individuals whose titer was very high to begin with, and in people who have reinfections, that on occasion you can make this diagnosis of serofast at a higher titer.
Yeah, there's a few questions around doxycycline, pre-exposure prophylaxis, and post-exposure prophylaxis, PrEP and PAP. Are you able to speak to how that might be utilized in the evidence for prevention of syphilis?
Yeah, so that's an emerging topic for sure. There have been 4 randomized clinical trials, 3 of them in cisgender, gay, bisexual, and other men who have sex with men, and transgender women, looking at the effectiveness of doxycycline as post-exposure prophylaxis for the prevention of bacterial infections. And they do seem to show a benefit, a reduction in syphilis among those populations. We at FAC have prioritized the development of recommendations on doxycycline for the prevention of bacterial infections, and that work has also started. I saw that there was a question about how doxycycline use might impact people's serologic test results and titers, and I think that's an important unknown. If someone is taking doxycycline on a regular basis, how's that going to impact your ability to diagnose, especially reinfections? So that isn't something that I'm aware that there's good evidence for at this point in time.
Okay, there's a question around diagnosis of syphilis in older individuals who might have symptoms that are due to other causes, so like a memory or vision change as an example that was provided by the individual. Are you able to speak to any aids in a clinical assessment to help with diagnosis of syphilis in those situations?
So I would think that if you had an older individual who then tested positive for syphilis and had these other findings, you'd be concerned that that might be the underlying etiology. If there's a concern that there are neurologic findings that might be related to syphilis, you may need to do a lumbar puncture to make that diagnosis. It could be complicated in the context of previous syphilis infections, of course, and the RPR titer can decline over time even without treatment. So it can get very tricky, and that might be a scenario where you may want to involve an infectious diseases colleague in the assessment and management of the individual.
Okay, well, that's all the time we have for questions today. As we wrap up our PHO rounds, I want to thank Dr. Andrea Chittle for presenting and thank all those who joined us for today's webinar. You can expect to receive a brief and anonymous PHO round survey for today's session. Please try to complete this to help us improve our programming. And lastly, to access past PHO presentations and to view confirmed and upcoming sessions, please visit the PHO website, head to Education and Events, and click on Presentations. Thank you all, and have a wonderful day, and hope you can all stay cool in this hot weather. Take care.